So I will get started with the epidemiology of early onset GI cancers, and again, how we can use epidemiology to inform the study of risk factors we haven't previously considered. These are my financial disclosures. I have 2 items on my agenda for today. I'll start with a quick refresher on increases in incidence rates of early onset GI cancers. I'll then spend the bulk of my time using early onset colorectal cancer as a case study for thinking outside the box, again, to identify risk factors we haven't previously considered. I'll do this by first talking about what I call usual suspects or well-established risk factors for colorectal cancer like diet or obesity. I'll then give a specific example of a risk factor we've not previously considered by sharing some of my own work on early life exposures or exposures that happen during the earliest periods of development like gestation and infancy. So as we get started, I think it's important to remind ourselves of the progress we have made overall in reducing GI cancer incidence and mortality rates. We've seen a steady, again, overall decline in incidence and mortality over the last 30 years or so. In this figure, you can see that both the number of new cases as well as the number of GI cancer deaths has declined since about the early 1990s. But as we all know, our progress has been turned upside down by the increasing incidence rates of GI cancers among younger adults. These increases, again, as you all know, contrast the overall declines that I showed you on the previous slide and really challenge the idea that cancer is a consequence of aging. In this figure, you can see incidence rates of GI cancers for persons in their 20s, 30s, and 40s over time since the early 1990s. And even though the rates are lower here than what they are for older adults, we can still appreciate that increasing trend in incidence and for each of these 3 10-year age groups. Increasing rates of early onset GI cancers have been driven by dramatic increases in early onset colorectal cancer, smaller but meaningful increases in early onset gastric cancer, as well as early onset pancreatic cancer. And although much rarer to some extent, we have seen an increase in early onset stromal tumors, and most of these are in the small intestine. We haven't seen quite the same increase in early onset liver cancer. And for rarer cancers like esophageal adenocarcinoma and gallbladder cancer, incidence rates have remained somewhat flat over time for this age group. Increasing incidence rates of early onset colorectal, gastric, and pancreatic cancer have become a frequent headline in the popular press and media. And although we were initially puzzled as to why incidence rates are increasing, we have learned some in the last 2 or 3 years about factors that may contribute. So using early onset colorectal cancer as a case study, there have been several studies of, again, what I call usual suspects or well-established risk factors for colorectal cancer in older adults, like obesity and diet. These studies have been conducted across a variety of settings, ranging from integrated health systems to large medical centers. And although there are some differences in how risk factors are measured, the findings are generally consistent. In this figure, I created a forest plot to illustrate associations of early onset colorectal cancer with obesity, Western diet, vitamin D, sedentary lifestyle, family history, and NSAID or aspirin use. These usual suspects increase the risk of early onset colorectal cancer. And in fact, this forest plot looks a lot like it would if the outcome was colorectal cancer in older adults. For example, we see elevated associations with obesity, although there are a few inverse associations, probably due to weight loss prior to diagnosis. We also see consistently elevated associations with Western diet, sedentary lifestyle, and family history of colorectal cancer, and consistent protective associations of vitamin D and NSAID or aspirin use. I do want to mention that even though I haven't included them here, some of these studies also looked at specific nutrients like fiber, fruit and vegetables, and red meat, and generally found small effect sizes. Again, very similar to what we would expect to see and what we already know about risk factors in older adults. I also want to call your attention to the fact that in studies comparing early and later onset colorectal cancer, there is generally no difference in the magnitude of risk associated with these factors by age. So I've included another forest plot here that illustrates risk ratios for the usual suspects in relation to early and later onset colorectal cancer. Again, for many of these usual suspects, the risk ratios are nearly identical. For example, if we look at sedentary lifestyle and alcohol use, we can see that risk ratios for early and later onset colorectal cancer are very similar, although there are wider confidence intervals for early onset colorectal cancer, as we might expect given the smaller number of diagnoses. The two forest plots make clear that many, if not all, of the well-established risk factors of later onset colorectal cancer are also risk factors for early onset colorectal cancer. And in studies that have examined differences in the association of risk by age, the magnitude of risk is really not that different. At the same time, with the exception of family history, these usual suspects have somewhat small effect sizes and likely cannot explain all of the increase in incidence rates. In fact, they probably never explained much of the variation in risk among older adults. I hear often from my gastroenterologist friends that they diagnose colorectal cancers in otherwise healthy people who are not overweight and do not have predisposing conditions, raising questions about unusual suspects that may contribute. To me, the most promising clue for identifying unusual suspects is the fact that rates of early onset colorectal cancer have increased successively by birth cohort or about the year that you were born. So in this figure, I've plotted incidence rate ratios by birth cohorts, which you can see along the x-axis. And there's a clear trend that incidence started to increase markedly among persons born in and after the 1960s, who we sometimes call Generation X. Now, this birth cohort effect isn't just a fun thing that epidemiologists like me like to describe, but it's actually quite meaningful because it tells us that exposures in early life, including during gestation and infancy, may be important risk factors. For example, there were several pregnancy-related exposures introduced in the 1960s, ranging from chemical exposures to certain medications prescribed during pregnancy, and that may contribute to higher rates of colorectal cancer among adult offspring exposed in utero. I've had the exciting opportunity to study early life exposures as risk factors for colorectal cancer in the child health and development studies. This is a multi-generational cohort that enrolled nearly all pregnant women receiving prenatal care in the Kaiser Health System in Oakland, California between 1959 and 1967. Very detailed clinical information was collected prospectively from medical records on maternal conditions before and during pregnancy, medications received before and during pregnancy, and labor and delivery. Importantly, these data have been linked to the California Cancer Registry to identify 83 colorectal cancers diagnosed in adult offspring, and for a period of follow-up that extends more than 50 years after their birth. This table shows characteristics of the 19,000 or thereabouts live-born offspring of the child health and development studies. You can see that just about half of the offspring were born in the early 1960s, and the cohort is racially and socioeconomically diverse. About 1/3 are racial or ethnic minorities, and about half were born to families with an income below the median, which was about $6,500 at that time. Now, we've studied several early life exposures in the child health and development studies, and I'll share more now about our work on in utero exposure to vindectin. Vindectin is an anti-emetic that was approved in 1956 to treat nausea and vomiting in pregnancy. It initially comprised 3 parts: doxalamine, which is an antihistamine, pyridoxine, a form of vitamin B6, and dicyclamine, which is an antispasmodic. After its approval in 1956, vindectin quickly became the most common treatment for nausea and vomiting in pregnancy. In 1962, however, there were reports of birth defects in infants of mothers who took vindectin during pregnancy, and many of these reports were fueled by concerns in the wake of the thalidomide tragedy that happened around the same time. Unrelated to those reports of birth defects, in 1975, an 8-way randomized trial comparing the relative efficacy of doxalamine, pyridoxine and dicyclamine demonstrated no clinical benefit of including dicyclamine, that antispasmodic, in the formulation of Bendectin. Therefore, in 1976, the manufacturer removed dicyclamine from the 3-part formulation. Several epidemiologic studies investigating the earlier reports of birth defects and that were later conducted in the 1980s demonstrated excess risk of gastrointestinal birth defects in infants exposed to Bendectin in utero, including pyloric stenosis and esophageal atresia. Production of the 2-part formulation of Bendectin was subsequently discontinued in 1983 in the face of ongoing lawsuits. Importantly, dicyclamine, again, that antispasmodic included in the 3-part formulation of Bendectin, continues to be used in clinical practice to treat irritable bowel syndrome and is designated as pregnancy category B by the U.S. Food and Drug Administration. Exposure to Bendectin in utero, and specifically to dicyclamine contained in the 3-part formulation, may target the developing gastrointestinal tract and contribute to higher rates of colorectal cancer among offspring exposed in utero in the 1960s. In utero exposure may also alter metabolic and epigenetic responses that increase susceptibility to diseases in adulthood, including colorectal cancer. In the child health and development studies, about 5% of offspring were exposed in utero to Bendectin, and the most common indication for its use was nausea or vomiting. The first prescription for Bendectin occurred at about 12 weeks of gestation, and the majority of exposed offspring were first exposed in the first trimester. Exposed offspring were also exposed on average to just over 1 prescription, and the majority to only 1 prescription. This table shows hazard ratios from the adjusted model of the association between in utero exposure and colorectal cancer. Overall, offspring who were exposed in utero to Bendectin had a higher risk of colorectal cancer. You can see the hazard ratio is about 3.6. Here I've added the incidence rates of colorectal cancer by in utero exposure. And these data generally follow the same pattern as the modeled data, where we can see that incidence rates are higher among offspring exposed in utero at about 30 per 100,000 compared to 10 per 100,000 among offspring not exposed. This figure shows cumulative incidence, or the risk of colorectal cancer, using age as the time scale, which is shown along the x-axis. The orange line indicates those exposed to Bendectin, and the blue line is risk in offspring not exposed. The 2 curves start to separate at a somewhat early age. We can see here that by age 40, there's already a difference in risk associated with in utero exposure, although that risk is very low in both groups. The unexposed offspring have a risk of 0.04%, and exposed offspring a risk of about 0.4%. Now, this difference in risk associated with in utero exposure persists across age. For example, by age 45, risk is 0.09% in the unexposed compared to 0.7% in the exposed. And similarly, by age 50, risk is about 0.2% in the unexposed compared to 0.9% in exposed offspring. So what does all of this mean? I don't think we've previously considered in utero exposures as risk factors for early onset colorectal cancer. But to me, these findings point to a specific effect of dicyclamine, again, that antispasmodic contained in the 3-part formulation of Bendectin, or perhaps a synergistic effect of all 3 components. As an antispasmodic, we know that dicyclamine has direct effects on the smooth muscle of the gastrointestinal tract. And as I talked about earlier, it's possible that in utero exposure programs the sensitivity of the developing GI tract or increases its susceptibility to carcinogenesis following additional exposures in adulthood. I'll wrap up by summarizing the clues that I think this case study on early onset colorectal cancer provides us about early onset GI cancers broadly. First, it seems clear that many, if not all, of the well-established risk factors for later onset cancer are also risk factors for early onset cancer. At the same time, these well-established risk factors, or again, usual suspects, cannot explain all of the increase in incidence rates. And there are likely many, if not thousands, of other risk factors or exposures that we've not previously considered. You, like me, may be wondering, what are these previously unsuspected exposures and what can we do about them? I'm excited for you all to hear next about new methods to identify exposures or the exposome and understand mechanisms, and then later more about strategies for integrating findings into clinical practice. Thank you all for your time. I'm going to hold questions and pass the baton out to Dr.